This is a very special webinar because we have a focused discussion on a difficult topic with some extraordinary experts. We're very fortunate to have Professor Marc Gewillig with us, and he is, of course, a world-renowned interventionist from Belgium, from Leuven, Belgium. He has authored more than 350 papers, and on a whole variety of topics, not just interventions. His work, his papers on Fontan are most popular and famous within this country because it has changed our concepts in the way we think about it. But he has got deep technical insights, which is why I especially sought him out and requested him to join us and share his wisdom. Along with him, we have some stalwarts from within India, Dr. Radhakrishnan, who's perhaps the senior most pediatric cardiologist within the country, and my senior, from whom I've learned a lot. Dr. Nageswara Rao, who is in Hyderabad and who is also very famous for the invention of the Konar MF device, which many of you are using now. Dr. Shreepal Jain, who is a young and very talented pediatric cardiologist from Bombay. So I think we have a very nice group. And what we have today, what we plan to do today is to have a conversation. We are not doing it in the conventional style where one speaks after the other, but we're going to have some discussion in a very structured way, hopefully, where I would pose some questions relating to this difficult topic. We're just going to walk through a case typically as to how we take those decisions at various stages and look at some challenges, and maybe we will have some case illustrations which will again highlight those challenges and how we will seek your opinions from the eminent panelists on how we should overcome those challenges. After this, we'll have a lecture from Professor Marc Gewillig, which will further enhance our learning in this area. And we will have then, after that, an open session where you can all ask questions, which will be addressed, I hope, systematically and comprehensively. So with this, we're going to start. I'll just start by introducing the other panelists, which you have. I'm sure you can come on screen, Radha and Nageshwar, as well as Shreepal. You must be able to, I think the audience should be able to see all of you. Marc is also on the screen. That's fantastic. So at this point, I'm going to share my screen and go to the presentation straight away. And so this, as I said, is going to be a conversation between us and amongst these three panelists that we are having, and Professor Marc Gewillig as well. So the way I look at PDA stenting is that it's a series of judgment calls. And by judgment calls, I mean there isn't enough standardization of the procedure. That's probably because of the tremendous variety that we see and unique challenges that we have. So the first question I'd pose to Marc and then to the panelists is, do you stent every patient who think is a candidate, every newborn with a duct dependence, pulmonary circulation, or are there patients whom you think cannot be stented? So that's the first question, and there's a follow-up question after that. So Marc, over to you. You can answer this question. Hello, Marc.
Yes.
Can you? Yeah. Go ahead, please. Thanks.
Sorry, I was muted. So clear answer: no, I do not stent every patient I come across. I think maybe every patient can be stented, but it is, as always in medicine, a balance between different techniques. You must know what your surgeon can do. You must know what you can do and at what risk. And so I can honestly say in some ducts, I'm far superior than my surgeon, and I have a very good surgeon. But in some ducts, there is a big risk, either procedural or in follow-up of the duct, where I think that sometimes my surgeon can do better. And what would be those cases? A very, very, very tortuous duct. But I will show you a few examples in my talk, what I still consider reasonable. And so if it's worse than that, or if there is significant hypoplasia of the branch pulmonary arteries, which mean 2 to 3 millimeters, and that especially in the absence of a trunk. If the stent at the pulmonary end, as we will discuss, always has to cross the ductal constriction, and if there is no trunk and it immediately goes to either pulmonary artery, which is then hypoplastic on top of that, I think the stent, you can do a good stent to one lung and you will lose the other lung. That may be part of a strategy, but I mean, you have to be aware of that is going to be a problem. And so that would, and then also the very, very long duct, with which I mean typically that will be a duct to both lungs coming from a brachiocephalic trunk or a subclavian artery. Those frequently can be enormously long, with which I mean 40, 45 millimeters long, things like that. And there, I think in the long run, sometimes my surgeon can do better.
So that's very nice. I'd like to quickly have a word from Radha and the others on this question. Radha, can you unmute, please? So, requesting you all to unmute when you start to talk.
Okay. KK, I'm still learning. No, I'm not the ultimate word. I'm extremely comfortable with the ducts which originate from the descending aorta. Those are patients with critical pulmonary stenosis or pulmonary atresia with an intact septum. Also, now I'm more comfortable with the typical ducts that we see with VSD with pulmonary atresia that Marc has been talking about, the tortuous duct. Of course, if it is very tortuous, I don't do it. When they are less than 2 kilos, I'm very uncomfortable. Having said that, the surgeon is also very uncomfortable trying to put a shunt in newborns who are less than 2 kilos. I'm quite happy with the shunt, the ducts which Marc was talking about, that is those ducts arising from the base of the left subclavian with the right aortic arch. I don't know. I have not seen such a very, very long ducts like Marc was talking. So I'm comfortable with that because it's a relatively straight course. But I have not seen the so-called very, very long ducts which Marc was alluding to. So if I see them, I'll be more careful now.
Nageshwar, quick.
I think I agree to some extent that disconnected pulmonary arteries with 2 separate ducts in a complex heart, generally I don't prefer to stent both. If at all, I will stent only small one. Second is, when you have 180 degrees tortuosity of the duct already mentioned, that is going to be very complex. Sometimes you may have to put 2 stents. But the indirect ductus, I think if it is less than 40 millimeters, KK, you have written more than 40 centimeters, maybe you can correct it. Less than 40 millimeters, I'm comfortable. My longest stent was around 36 millimeter, we put that. Not all cases, sometimes we may do 2 stent strategy. I'm not disagreeing with Marc, but these are our views because our surgical results sometimes are pretty much poor in neonate with the duct. That is the reason probably we are forced to do some of the cases.
Okay, Shreepal, anything to add? Other than, is there any specific insight that you want to share?
Other than the indications which other people already mentioned, the one more indication where I would be a little worried for stenting would be a presence of stenosis of the branch PA. So especially when you have PDAs from the undersurface and inserting to, say for example, a left arch with a left-sided PDA inserting into the left pulmonary artery, where it is not at the confluence, but at the probably a little more distal than the origin of the left pulmonary artery, and then you have associated LP stenosis. Those would be the ducts I would be a little worried, because then, I would have to go inside the pulmonary artery and then probably end up jailing one of the branch PAs. So that's another indication where I would be a little worried about stenting such PDAs.
Fantastic. I think that really sums it up beautifully. So I'm just going to summarize the ones which there's sort of agreement out here. Very tortuous ducts, and Nageshwar defined it as greater than 180-degree turns within the ducts. Significant hypoplasia of either branch PAs which are disconnected, especially if they are disconnected. The disconnected part should come in the next one. Very, very long ducts. Something that some of us have seen, and I have had one or two cases where I have had very long ducts in the context of disconnected PAs, and I have ventured into stenting them because we didn't have any other option because they were duct dependent. But that's a real difficult challenge. And then when there is significant hypoplasia of either branch PAs, where the duct just continues and branches off into branch PAs, and where you're going to sacrifice one, and then there is stenosis at PA origin. I think these are all reasonable levels of difficulty that we should avoid. So the one thing that I do, and I think here Nageshwar and Radha and others will also agree, is that I spend a lot of time echoing these patients, and I try to look at and create a mental picture. It's not easy because you can't actually entirely create the 3D reconstruction of all these patients. I try and imagine all the twists and turns. I try to understand the approximate length. I can often be wrong. And I try to see the PA insertion in detail, especially the origin stenosis, if there is at the PA insertion site. So this is something that we do. I find that these measurements can be completely erroneous when we look at the twists and turns, when we try and understand this. So for that reason, I think there is increasing preference to obtain a CT scan. So quickly, I want to ask the panelists, do you always obtain a CT scan, or do you sometimes obtain it when you suspect very tortuous duct? So Marc, and then I'm going to ask the others.
Okay. To be honest, I have never done a CT scan in a patient before. Stent insertion in a duct. But allow me to say what all the questions I need a decent answer for, and usually I will get it by the echo. So I need to know, is the duct going to one or two lungs? I need to know what is the angle at the aortic end. What is the angle? What is the relation with all the neck vessels? Is it coming anterior, inferior, or lateral? That's the specifically for the angulation on the cine. And then the pulmonary end, where is it? The size of the left and the right pulmonary artery, the size of the trunk. And then for my distance, as you will see, I usually will straighten the duct with a very stiff wire, almost the way that the stent will do it. And I will measure in one plane where I see the aortic end and the pulmonary end, whatever the duct is doing, because that's what my wire is going to do, and that's what my stent is going to do. And that is the measurement I usually will use, plus 2 or 3 millimeters either end. That will usually be the final size of the stent. So if I don't get the answer by echo, I probably would go for a CT. But so far, I've had always a decent answer by echo, and I have never felt the need for the CT. I do agree, however, I've seen very nice pictures for a CT, but having done now over 150 ducts without one CT, I think that the point I can make is you don't need it, but it might be useful.
Okay, that's fantastic. And this is sort of almost identical to what I do, but I'm going to ask others if they have any preference for a CT. Do you disagree, or do you have any differences with Marc on this view?
I do the CT if it is a very tortuous duct, the so-called multiple turn duct. I have started doing CT to get a better hang of it.
Nageshwar?
It's an extremely rare phenomena for me to do a CT scan. Whatever decision we take by echo, if I feel that we should do surgery in those cases where we cannot do intervention, then probably I would ask for a CT scan. By and large, CT scan it's an extremely rare to do in these cases in our center.
Shreepal, any differences of opinion?
So from the point of view of stenting, I would just reiterate what even Nageswara Rao sir said. Like when you have a tortuous PDA, especially when you have more than two bends and one of them is more than 180 degree or like 180 degree, probably those are the cases not really suitable for stent. So there is no point asking for a CT in such cases. Probably rather send them for surgery. Another important thing is many times we are a little confused as to the exact insertion site of the PDA on the PA along with the ipsilateral branch pulmonary artery. So that is one of the cases where I would consider doing a CT. One more important thing about doing a CT is that I can really plan my fluoroscopic views based on the CT as to the best possible fluoroscopy that I can see in the cath lab for stenting such cases.
So there is this study that came in CAT CVI where they felt that it really, 3D reconstruction aids in planning ductal stenting. So I'll just summarize our single center experiences. Data has not been updated since September 2019, but in that period, we had done 54 consecutive patients in our own center. We have taken 52 for PDA stenting based on our echo assessment, and 2 were abandoned after the angiogram, actually. Which perhaps would have been candidates where, we didn't completely anticipate. One was extremely tortuous, 360-degree turn. And the other one was actually a complete occlusion that we could not cross. We wanted to cross it, but we did not. So this is our experience in that period of time. Since then, I haven't actually had anybody that we have had to do a CT or abandon after the angiogram. Probably done another 50 cases after that. So this is the data from our center. I will ask some other really difficult questions which some of us encounter. Firstly, quickly, I want a very short answer. When do we stop prostaglandin prior to taking up a newborn for ductal stenting? So I'll start with Marc and then I'll ask the panelists.
When do I stop the prostaglandin? Well, in a tortuous duct, never. Yeah, yes. I will stop it when my wire is across the duct. With a straight duct, and there I mean with the duct like in prostaglandin, in the pulmonary atresia intact septum, there usually the problem is that the duct is too large for retaining the stent. And there typically, most of those patients nowadays come fetally already. And so we know before birth that they will have that. And there the thing is that I forbid my neonatologists to start prostaglandin until the patient turned somewhat bluish, until he had saturations 85 to 80, something like that. And only then they may start the prostin, because otherwise you end up in the cath lab waiting for a duct to constrict, and that may take sometimes hours. So in a tortuous duct, never. In a straight duct, late start and early stop. In those ducts, it's usually the issue of having the patient as blue as possible in the cath lab in order to have a safe retention of the stent.
Shreepal, when do you stop?
So, yeah, unlike Professor Marc, I think we are not that fortunate to have most of the kids being diagnosed really well ahead of time. Most of our kids actually come crashing. So, we end up starting prostaglandin at a really high dose so that we can open up the PDA. So by and large, we usually know when we are reducing the dose of PG even after the kid has stabilized as to how soon the PDA is responding to the dose of prostaglandin. So accordingly to that duration is what we are going to plan. But for those where the PG even has been electively started, it is usually about 6 hours that we start, we discontinue the prostaglandin and then monitor the saturation in those cases.
So I'm going to ask a slightly different question to you, Nageswara. Have you had a situation where you could not stent because the duct was too wide open and you put the patient back onto the NICU and then you got the patient back the next day?
Yeah, actually it happened a couple of years back. The duct got dilated too big that it was more than 4 millimeter. Then we stopped it and we took after 2 days. We had that situation when you start prostaglandin for long period of time, maybe 2-3 days, then you may end up with that situation. That's the reason now we adopted a policy. We do echocardiogram previous day. If duct is too big, will stop prostaglandin 4 to 5 hours before the procedure. If saturation is still low, duct is lesser than 4 millimeter, we are not comfortable in stopping the prostaglandin, and baby will go to cath lab with the prostaglandin vial or prepared syringe. Eventuality, what Dr. Marc said that tortuous ductus are more prone for spasm in the lab itself. So large ductus, we had a problem in the past. If you start for long duration of time, they will have almost like aneurysmal situation.
Okay, Radha?
Yes, I usually stop prostaglandin in all patients 4 hours before the procedure, but it is kept connected, of course. And if ever I notice that there is too much of constriction, I would restart it.
Okay. I think what Marc said actually makes eminent sense. And the only problem is we've had occasional tortuous ducts that are really large. And we're still a little worried about stenting them, because sometimes, and we've had that situation where the stents have actually got displaced. That's why I tend to wait, tend to be very careful about ensuring that you have some grip on the stent in many of the cases. But mostly the tortuous ducts often allow you to stent them even if they are on prostate. So quick question again, is there any merit in delaying stenting in a newly born baby? In the sense, we tend to wait for a couple of days. We don't tend to take them on day one. Again, I'll ask Marc and I'll ask the others.
Okay. Well, I like to have the baby at least dried after birth. I don't like wet babies on my table. But now, the only patient where I will go for a fast stent implantation is the one with like a fellow with one lung on the pulmonary trunk and one lung on the duct, because that duct usually will be a small duct in a patient which is well saturated because of the other lung, and that duct, despite prostaglandin, will tend to close whatever you do. So if you wait 2-3 days in those patients, you will end up with a closed duct. So that would be the duct I will take within 24 hours. All the others, I don't mind to wait.
And what about preterms?
Say it again.
What about preterm newborns? How about if you have a very small preterm, let's say 34 peaker with a duct and a duct-dependent circulation, who's, let's say, 1.6 kilos, do you sort of throw them on prosta?
In the good old days, I think my record 20 years ago was keep a preterm for 2 or 3 months on prostin, and then do whatever we needed to do. Yeah. So I know that you can do that. I would say what a preterm child is concerned, everything will depend on, will it tolerate a 4 French sheet, yes or no? Frequently you can go with a 4 French sheet from venous side, and then my threshold will be rather low. Or if you have to go carotid in any way, it is indeed an option to go through the carotid of a premature, knowing that, for instance, if my neonatology team goes on ECMO on children, I mean, they tie off one of the carotids. I mean, it's not my preferred thing, but so if I can wait in a preterm in safety and comfort, I will try to go for 2 kilo or more. If not, I will proceed.
So a quick question to all of you. I mean, one by one, I'll ask Radha. Do you sort of wait for a few days for a newly born baby?
I wait usually for about a week. I mean, in our country, there are issues of sepsis and things like that. I would like to sort that out before. And of course, they are much drier that way. Well, if not for a week, at least 3 to 4 days, I would definitely wait.
Any disagreements, Nageswara and Shreepal?
Absolutely. I would prefer to wait in preterm babies a little bit to maturity. At least 2 weeks, I would prefer to wait in preterm babies. Otherwise, they don't tolerate the procedure.
Okay. Shreepal, any differences of opinion?
Nothing, sir. I agree with Radha, sir. Minimum 3 days for newborn babies we need to wait so that, we get rid of the transitional circulation. We have the PVR, which is low down, so that managing these kids in the post-op ICU is a little better.
Fantastic. Okay, what determines your choice of access? Well, I think we should discuss access also. So I'm sure the access is dictated by anatomy, and I'm going to listen to Marc's views on that. He's written a very nice paper long ago. In fact, one of his early papers actually identified all those issues, and would also ask about the unusual sites, because my preference is axillary and I know that Marc does carotid. So let's just have your summary on the access, Marc.
Okay. So, I mean, in some cases you will go venous, like in pulmonary atresia and intact septum,
yes.
you burn a hole through the valve and you go venous.
Yes.
I also will go venous in the brachiocephalic trunk. Usually you go right ventricle, VSD, aorta, because it's a fellow type something frequently. And so if you can do that, I'll do it that way. However, and then all the other ducts that are a straight shot from the groin, femoral artery, there I will go femoral artery. But now the tricky ones, that is the vertical duct, the tortuous ones, or, I mean, between horizontal and vertical, there my preference will be one of the neck vessels. And I used to work to go from axillary. I must say that since the paper from Texas appeared, that they did 100 consecutive patients from the carotid without significant problems. I have to admit that the carotid is a bigger vessel, maybe a safer vessel, and as long as you don't send a clot to the brain, it's probably the better vessel to take off. So I try to avoid the neck vessels, but I mean, I will not hesitate to use them. And currently I'm shifting towards carotid.
And do you percutaneously access the carotid, or do you do a cut down?
Sorry, say it again.
Do you access the carotid percutaneously, or do you do a cut down?
I started off by cut down, now I do it percutaneously.
With ultrasound, we can talk about that soon.
With ultrasound, yes.
Yes. So, any differences, any insights from the three panelists?
I use the femoral artery for the duct which comes from the descending aorta as well as from the base of the left subclavian. With the VSD, I would choose the femoral venous route and cross the duct through the VSD. And then, of course, now more frequently started using the axillary. I have used only once the carotid, but might use it more frequently. So if it is a tortuous duct from the undersurface, I prefer axillary.
Nageswara?
Yeah, I agree with Radha sir. In case of pulmonary atresia, intact septum, where we want to do perforation, then femoral venous approach, then undersurface of the arch indirect duct, femoral artery. We were doing a lot of carotid cut downs and carotid percutaneous earlier using the left carotid, not the right carotid, undersurface of the aortic arch vertical duct. That we stopped that procedure because we found that the right axillary is much more comfortable to operate from the fluoroscopy table. So now we switched over to right axillary. We were doing a lot of carotid. We did close to 40 cases carotid approach. Now we are predominantly doing right axillary. Right axillary, I feel, is more comfortable than any other method at this point of time.
Shreepal?
For vertical PDA, we also used to access the right axillary artery initially, but now we are slowly moving towards the carotid via surgical cut down. We haven't yet really tried percutaneous access for the carotids. And for the horizontal PDA, as everybody mentioned, we also prefer the femoral arterial approach.
Okay, so I'll say that, my preference is that we want the straightest trajectory to the PDA. It determined, to some extent, I take into consideration arch-sidedness, the origin of the duct from the aorta, the angle, the takeoff and the course, the weight of the child. Sometimes that's an issue. The axillary is forgiving, carotid is most forgiving, and femoral, I think, is the least forgiving of the three axes. And the femoral vein is a very useful alternative in selected situations. So these are the brachiocephalic artery, for example. This one best accessed from below, as Marc was suggesting, from femoral vein is a superb way of doing it. If you can go through the VST, the only risk sometimes you have in these little babies is when you are deploying the stent, if you have the catheter rub against the conduction system, you can have transient heart block. And that's something in very small babies that we have seen. But this one should not be accessed from the axillary artery because the angle can be very, very disconcerting to try and get into the duct. It's much easier to be accessed from either the femoral artery or the femoral vein. Here are some other examples of vertical ducts that, again, as Nageswara was suggesting, we all prefer to go from the right axillary approach here in this country, but I think the carotid is an excellent alternative. Another example where the duct is coming at an angle from the aorta, and this again is very well suited for the axillary approach. This is another example of a tortuous duct, which is ideally just beneath the bovine trunk, you can see out here. So either of the vessels are great alternatives. And this one is just facing the left axillary artery. Now here, the left subclavian artery. And the big advantage here is that you don't need a long sheath. The short introducer sheath will allow you to do angiograms. So this is a great option in very tiny babies where you can get a 4 French sheath inside, and just through that, without a guiding catheter, you can actually do your ductal stenting. And I do that very often. So just to summarize, the vertical duct, this is an example where you can use either left axillary or right axillary or the carotids. And here is something that you prefer to go from the groin. And to enter the duct, sometimes you often need a cutoff pigtail rather than just the right coronary, because there's a tiny downward trend. Now, you see this very often, and I think others will endorse that. This is the duct which I showed you an example of, the brachiocephalic. And the final one, of course, is always from the femoral artery and with the right coronary catheter. So these are my personal preferences, but I think it's in line with what others have been saying about the choice of axis. Question, again, do you use the ultrasound axis? And I'll start with the Indian operators because I'm assuming that Marc would always use the ultrasound axis. I'll come to him, but Shreepal and Nageswara after that.
Option 4, sir. Only if I fail with blind axis.
Nageswara?
Yes, only if I fail the blind axis, we have a specialist here. We take his help. Otherwise, by and large,
aren't you concerned that you can damage the vessel during the blind axis?
Probably I am not against of what is that ultrasound, but we are not comfortable at this point. We don't have coordination of that.
Radha?
Blind.
So I have switched to 100% ultrasound guided access for the axillary approach, because the younger ones, actually this hand-eye coordination is superb with the younger anesthesiologists who get the access for me. It is done within 30 seconds. It's amazingly quick. And so I have completely switched over, and I'll ask Marc if they ever do the blind access anymore in your center.
First, I must say that I'm very comfortable with doing it so-called blind access, but I demand now from the younger fellows that I train that they go full under echo guidance. I think when you master that technique, it's far out better. Right now, I'm still very good with the blind access, but I should shift to echo guided puncture. But it's so much in my hands that I can do it blindly and fast that I should push myself to go for 100% echo guided puncture, I think. And that's what I demand from my new fellows.
So that's what has happened in our own institution. The younger ones have really learned they've got the hand-eye coordination. So I actually approach all these babies with a very fine cannula, and I put a coronary wire, and then I insert the cannula and exchange it with the 018 wire. And then, I use a Terumo sheath. The advantage, and I'm not promoting any one company, but this one sheath is so much superior to every other sheath that's available because it just goes in really smooth. and does minimum damage to the vessel. And there is really no gaps between the wire, the dilator, and the sheath. So you don't even need to give a nick to the skin in the. So that's what I have been doing in the sequence that I have been following. Otherwise, you can have some injury to the vessel, and that's how I have seen that happen. So quickly, thresholds and sheaths, we need to answer, because there are people who are learning here, and I'm sure that they will value this opinion on this. And so I'm going to ask, maybe Shreepal, you can fill the first column, less than 2 kilos, femoral artery.
Yeah, less than 2 kilos femoral artery, we usually try to avoid the femoral arterial axis. If possible, either it's a femoral vein or maybe a surgical cut down if possible. For axillary artery, it's a 4 French, and for carotid, it's 4 French or 5, depending on what size we are planning to put. But mostly it's a 4 French.
So I'm going to ask Marc, would you be comfortable with a 5 French in a less than 2 kilo child through the carotid? I think so, but I'm going to ask you anyways.
Well, I can do anything I want to through a 4 French. I mean, I can get even a 5 millimeter stent through a 4 French sheet. So I do not have the urge or the need to use a 5 French introducer sheet. So I typically will use the 4 French flexure sheet in almost every patient.
What about a situation where you need to put in a guiding catheter at the mouth of the duct? Do you have 4 French guiding catheters, or is it, because the minimum size we have is 5 French?
I always try to get with my 4 French flexure sheet just in front of the duct, and so that's why in a vertical duct I will come carotid or axillary, and with a horizontal or a downward duct I will come from the femoral artery. But last 5 years I haven't used ever a bigger than 4 French sheet in a newborn. I do everything through the 4 French. It allows me also to make the nice angios, to get the push, to get my wire in place, the stiff wire. I do everything through the 4 French.
So Nageswara, I will ask you, because I think you are in similar situation as I am, because we don't have the 4 flexor long sheets. What we use instead is a 5 guiding catheter, coronary guiding catheter, which we are forced to use a 5 French sheet. So are you okay with the 5 French in a 2 to 2.5 kilo child?
No, what happened, if the axillary approach is there, 5 French is reasonable in a 2.5 kilogram baby. I'm quite comfortable with that. Now the question comes less than 2 kilogram. We don't have 4 French system. We have only 5 French system. We had come across a situation of 1.8 kilogram PA IVS. We perforated. We wanted to do the duct through femoral approach. What we have done, we took a 4 French sheath both sides, and you stent bare. You go with the assembly, entire assembly over the wire, and take another axis to give injections. So I don't use a guide catheter at all when we want to use the 4 French sheaths. Once you cross with the 4 French Judkins right coronary catheter, put the wire, take straight away stent, use another axis to give injections. So that is what the method I approach.
But you will use a 5 French in a 3 kilo child or 2.5 plus kilo child.
About 2.5 kilogram baby, we use 5 French in axillary, sometimes in femoral artery as well.
Okay. And once you go to 3 plus kilos, then I think you're okay with the 5 French in the femoral artery if you have to use a guiding catheter.
Yes.
Shreepal, you had a statement to make?
So there is this Cook CHB sheath which is available, which is 4 French, which can take most of the stents for kids.
Correct, but that's actually 5 French. I've realized that. They say it's 4 French, but when you measure it, it's actually 5 French. Especially when you've inserted a good portion into it. And also the transitions are not smooth, so it does more injury to the vessel. Radha?
I don't use 5 French in the femoral artery. I will use a 5 French in the axillary, but just whatever Nageshwar said, I take 2 axes if I have to use the femoral artery. One for a good angiographic shot, and if you actually inject fast from the sheath, you are able to visualize the horizontal duct very well, and then cross with one and use the other sheath for a dissection.
All right, so we'll go on to the next questions. Now we have a challenge with bare metal stents, don't we? We don't have them manufactured anymore. And now we ended up, I think we've slowly started to have, we are forced to use a drug-eluting stents in newborns. There is some concern about the material that's added on to drug-eluting stent, which can actually, there are studies that have shown that you have significant elevation in levels of sirolimus, and whatever anti-proliferative material is there. I'll ask Marc, do you have access to bare metal stents of all sizes? Or do you use drug-eluting stents?
We still have a few bare metal stents left. But I mean, I also work in a specific situation. I'm working in a general university hospital. And so I share the cath lab with my adult colleagues. Yeah. And so I have a whole variety of coronary stents. I have a whole closet. I mean, they have maybe 100 stents, different stents in stock on the shelf at all times. Yeah, including covered stents, covered coronary stents, everything. Yeah, and but I see that they keep now the metal stents, the bare metal stents, just for me. Because they are hardly ever using bare metal stents. And I expect within a year or two that we will not be able to buy them anymore in the European community, and that everything will become a drug-eluting stent. So it's a dying race.
So are you concerned on putting in a drug-eluting stent in a newborn?
The concern was there 4 or 5 years ago. They did some measurements. Okay, they can measure some levels. They're still minute. I haven't seen significant secondary changes, but I don't know also what that will mean in the long run. Personally, I haven't seen problems with with the drug-eluting stents so far. So I think they are more or less comparable. In the very beginning, they were very concerned, and they thought we were giving chemotherapy to our babies without having cancer, but the dosages are very small, and I think that's something we will have to live with.
So any concerns, Nageswara? I mean, I'm sure you're forced to use drug-eluting stents now.
We are all using only now drug-eluting stents. We had only 1 or 2 leftover bare metal stents. Otherwise, we don't have. We are forced to use. We use Release is a company here, and Medtronic company too. We use here, but both are drug-eluting stents.
So I'll move on. Stent diameters. So let's ask, what should be your diameter less than 2 kilos? Shreepal?
So usually we prefer that the kid is more than 2 kilos before we stent them. If I had to, then probably my choice would be a 3 millimeter for less than 2 kilos. Between 2 to 3.5 kilos, it will be a 3.5 millimeter stent, and anything more than 3.5 kilos, it would be a.
Okay. So I am more conservative, but I'm going to ask Radha and others their opinion.
When we started, we spoke to the surgeon, what is the size of the shunt that you would use. So I would agree with Shreepal, less than 2, it's always a 3 millimeter stent, then 3.5. I have not used a 4 millimeter stent till now. I would prefer to keep it at 3.5 at present, even for.
I personally use a 3 for anything less than 2.5 kilos, personally, because I find overcirculation, particularly if the duct is short. It's long, then I think you can get by with a relatively larger stent. Nageshwar, you have any preferences?
Yeah, we use extensively 4 stents in the past above 3 kilogram babies. But what we now do is, if the child is presenting to you beyond the neonatal period, that is more than 1 month of age and more than 3 kilogram, definitely I would prefer to put to 4. Anything lesser than that, we are going with 3.5. And it's extremely rare to do less than 2 kilogram, where obviously I agree with all of you, 3 stents. It's a very rare to do that. but 3.5 is by and large is the stent. If baby is matured enough, above 1 month of age, I think a 4 millimeter stent is not a bad idea at all. They last for long time.
Mark, your children are going to be bigger, so I'm going to ask you.
Yeah, we have bigger babies. I would never. What you may not forget is after you implant a stent in a duct, the ductal tissue will constrict, and the tissue will prolapse through the mazes of the stent. So whatever you put in there, the next day or within 2-3 days, the lumen will be smaller than you intended it to be. Yeah. So if a surgeon did put a 3.0 shunt somewhere, at least we should put a 3.5 or even sometimes a 4 if it's a long stent, in order to get the same result after a couple of days. One rule. Second rule, I would never go below 3.0 millimeters, because again, if there's some prolapse of that tissue of even almost 1 millimeter either side, a 3 millimeter stent already became then 1 millimeter opening, which is very small even for a tiny premature baby. And so I would say indeed for the less than 2 kilos, it's 3. For the ones bigger than 3 kilos, I would go straight for 4, presuming that these measurements are for double lungs. Yeah, for single lung, I will take 1/2 millimeter off.
Okay, that makes a lot of sense. I'm going to come to stent length later, because that's not a decision that we often take before the case is done. So quickly, I don't think this is I'm going to spend too much time here, because I think this is pretty much straightforward once you have your access sorted out. But I just wanted to state that I use the cutoff pigtail in selected cases. When I approach from the femoral artery, it really hooks the duct much more easily, especially if it is not PAIVS. And I'm sure the others also use this option. Nageswar, any choices? Anybody wants to say anything different in this
Yes,
situation?
I do.
Yes, tell me.
I also started off like this because in 10 years ago, I was afraid from axillary access and carotid access. And so indeed, with a cutoff pigtail, you can probe the duct, but it is increasingly hard then to get a stiff wire through it without the use of a bended the guiding sheet. And at the critical moment, I mean, I have had a few failures where I was unable to push the stent through the duct at that 180-degree angle. And I mean, I've had a few failures like that. And since I changed to carotid approach or axillary approach, my success rate went all the way up to almost 100%. So I would nowadays. Sorry?
The more you're referring to, the more sharply angulated ducts. I'm talking
like
about
that one.
Yeah, like these two, the first, second. I'm talking about the third example where sometimes with the JR catheter, you don't actually cannulate the duct, and it's easier with the cutoff pigtail, but they are more or less horizontal. This is the variety that I find the cutoff pigtail specifically useful, but otherwise I use the JR.
Yeah. So if you remain, I mean, if your wire remains horizontal at an angle of 90 degrees, there I would agree. But if you need an angle more than that, I mean, you can probe it. If you're lucky, you can put your wire in it, but you may run into trouble with pushing the stent into the duct. And that's the critical point. And so if nowadays I rarely use the cutoff pigtail for that indication.
So I'll come to the, go ahead, Nageshwar.
Some of the cases where we can't cannulate and thread the wire, we tend to use actually micro catheter. There is a catheter called Pro Grade. Especially in case of late presentation of TGA, that Marc may not be seeing that. When I want to cannulate and then perforate the duct, we put the micro catheter, support, and then use it. Even in tortuous ductus also, we take a micro catheter to the first curve and then advance your floppy wire like a whisper wire or run through wire, then it is useful. That is the only minor change in case of complex ducts.
Okay, so I'm kind of running short of time, so I'll move a little faster now. We've talked about all these.
Can I give a comment on the last comment?
Yes, please do.
A very firm statement. I repeat, always use the ProGrade when I'm putting my wire through the duct. That allows me to get a very nice distal position of my wire, a very stable position, and it also allows me to get a stiff coronary wire through the duct. And I think, it depends on the technique. I see that some of you use whispers and things like that and body wires. I always go through the duct with the ProGrade. I then exchange it for a stiffer wire, as stiff as I can get. And for that, you need the microcatheter. Once you have that wire in position, you put the stent anywhere you want to. And also, by then you will have straightened the duct, and you will know exactly much better also what length and what size you will need. So the choice of how do you cross the duct with which wire, do you use a microcatheter, yes or no, and the stiffness of your wire will depend heavily on what stent you will use and your final result. So I think the choice of that technique already determines your technique and your final result, I think.
Perfect. I think that's very well said. We also use it, but we have constraints of using too much of hardware, so we tend to be a little conservative, especially these catheters. Microcatheters are relatively expensive, so we tend to reserve them for our tortuous ducts, and for the relatively straightforward ducts, we just take a coronary wire and do it. The Whisper Extra Support has a softer distal portion and a relatively stiff body, so that is a little better than the pure Whisper. Whisper is very floppy, so we tend to avoid using the Whisper in these situations. So I'm going to go quickly. I'm not going to come to this. I'll try to move on to the other issues, which is angiographic views. So the question is, how do you minimize contrast and radiation dose? I think we have to be mindful of radiation dose also, and we have to try and use the fewest angiograms. So any strategies, Marc?
Yeah. Well, when I get in, I make an aortogram just to have an idea without having crossed the duct. Now, in order to reduce radiation, my scopy machine nowadays is so good that I tend to work only with recorded scopy. Yeah, and that already reduces a lot the radiation. And so typically I will make an injection blank, just to see how the duct looks like. Then I will cross it with the wire with a microcatheter, and then once I'm across, I will put my flexor sheet very close by and make an injection. And so typically that flexor sheet will just catapult the contrast into the duct, and you will see much better your aortic end and the pulmonary end. That's almost the only thing that interests you. Based on that, then I will fine-tune my size. So that's two injections so far. I will then put in the stent where I would think it should be, make a last contrast injection to make sure that the wire is good. So that's my third injection, but that's 1 or 2 cc's, no more than that. And if I'm happy with the stent, I will deploy it. If I'm not happy with the stent, and that's an important point, I'm able to exchange a stent and exchange it to a longer or a shorter version within 90 seconds if required. But you need to be able to do that. And then inflate, deflate, get the balloon out, and then make the final injection with still the wire in. If I'm very pleased that I caught both ends, I will take out the wire without further injection. If I'm not very sure, then it depends what the problem is. So I can do it with 4 injections, but only 1 aortogram, and all the rest is little small hand injections, half a cc or a cc.
Yeah, so that's sort of what I try to do most of the times. And it's a good point. If you have very good quality fluoroscopy, then you don't need angiograms. And that's a massive reduction in radiation for sure in these little newborns. And I also try to wire the duct straight away as quickly as I can, then use the view after that and start doing the angios only after that, rather than taking multiple angiograms before your wire is across. So that's sort of the view. So here is an example I'm just showing for the sake of everybody else. So here's an example of the injection through the axillary artery sheath. And in this PA view, you can see everything is overlapped. And when you do it in the LAO view, you can see the origin of the duct can be easily identified more clearly. And you can then wire the duct. And it's probably even not necessary to do this angiogram, but it gives you a better roadmap in this particular situation when you go to the LAO view. It's important to imagine these views when you've done your echoes or if you have, for some reason, done a CT scan. So I'm, in the interest of time, moving a little faster. How do you identify the aortic and the PA ends precisely? I think the PA end is more challenging sometimes. Here is an example where it's very straightforward. You can see the PA end, there's no problem whatsoever. But here is an example where you see it's not clear where the PA end is. It's got a lot of overlapping structures. So again, Marc, and then I'll ask the others, how do you overcome this problem?
Well, I must say that when I position, I usually will see the PA end best in the lateral, yeah? And when I position my stent, I would never do it on this frame in an AP, but I always will do it on the lateral. The covering the PA end is the most critical one. And sticking out a few millimeters in the aorta usually doesn't matter that much, yeah? So I would, I presume you work in biplane, but I mean, I would never ever put a stent in this view. Yeah, okay. I would go for the lateral because there you will see much better the PA end.
I think it makes sense. The lateral is by far the most consistent in identifying the PA end. Any views, any differences in this opinion, Nageswara, and then I can ask Shreepal as well. And Radha?
I think if you have tortuous duct and inserting under surface, sometimes you take angulations, either cranial angulation. Very rarely we take a caudal, but a cranial angulation with a shallow LAO or AP cranial angulation will show the ductus to some extent. So to avoid that confusion, we'll put the first wire and then screen the wire whether it is aligned properly without curvature. Will give roughly some idea which view is going to be better. So I do some cranial angulations in these cases to identify LAO cranial is based on the ductus anatomy. We do that, but plain AP by and large we would like to avoid.
So we don't use all. That's absolutely right. So here
so we usually try to put two wires. So in each pulmonary artery. So you know the point at which the pulmonary arteries are separating from each other can usually give you a rough idea as to the PA end of the PDA.
But then there's slight confusion sometimes because the wires separate from each other within the duct, and you may get fooled on where the PA end is. Sometimes I've tried that, but that's been a little bit of a problem. But that's something which I think the point that Marc made is very, very valid. The lateral view is very consistent. And here is an example of the lateral view where you can see the duct insertion very, very well, and you can be quite sure. And the other thing I want to illustrate through this angiogram is that if you have a good MPA stump, then it's not a problem about where the PA end is. You can be very generous with your stent and take it well into the MPA, and then just focus on the aortic end after that. You can take a relatively longer stent and feel comfortable with how you deploy this particular stent. This is something I always try and do, where I try to put the wire and make a loop in the MPA. If there is an MPA stump, I always make a loop.
Yeah.
Here is just an example of a duct that has been stented in that fashion.
Yeah, absolutely.
And I find, the aortic end is identified by the nasogastric tube in the lateral view. quite consistently. And some protrusion into the aorta is absolutely okay, as Marc emphasized, and echo is sometimes helpful, but I'm going to show you an example where it's been a problem. So this is a quick story which has been quite an illustrative case, and I'm going to sure it's going to generate some controversy. So here's a 2.3 kilo child, day of life 7. And the child had pulmonary atresia, but we didn't realize that he had an aberrant right subclavian, which came off this way. And if you look at this angiogram, it's not a great angiogram because it's a very short loop, but you can see that the aberrant subclavian comes off a little distal to the duct. It was slightly difficult to cannulate the duct. We got the wires in place, and this is the position that we had of the duct. And I'll go to the next angiogram. So we thought we had it all covered. We had the stent. Now here it's well into the PA end, but it's definitely more into the. It's also crossed the aortic end. We withdrew the stent slightly, and we felt that we've got the perfect deployment because we seem to think that the aortic end is also covered, the PA end is covered. So we removed the wire in this particular case, and all seemed well. And echo appeared to suggest a very good position, both in the PA as well as the aorta, and the good flows initially. So we removed the wire, but then the patient really desaturated and became bradycardic, and we had to give CPR. I had to obtain new femoral access. Actually, it was just as, and we had actually gotten rid of the axillary access by then. And this patient was being given CPR as I got a femoral access, and we found this particular phenomenon. And what we realized then is that the aortic end, what we thought was fine when we removed the wire, had actually now slipped inside the duct. And this patient's duct had gone into a spasm. The only thing I did at that point, which I thought would rescue this child, worked, which is to give a bolus of prostaglandin locally, and we were able to restore flows in this patient. When we looked very carefully, we realized this is what had happened. The duct had, the stent had slipped into the aortic end in this fashion. And I realized that I could never cross this duct through the central lumen. I would have to cross it through the side struts and waste a lot of time. So I kept this child on prostaglandin, and we had the child in reasonably good saturations and waited on this child. The next week, the child was fine in the ICU. The saturations were initially in the 70s, but they became mid-80s. We were able to taper off everything. And the child remained so after 7 and now 14 days, and the child is doing well. And the echo showed this phenomenon. The stent is sitting right at the aortic end of the duct, but not into the aorta as such. The flow is mostly through the side struts. So we're watching this child carefully. We would probably perhaps go on to doing a VT shunt whenever the SATs decline. The child is still quite small, 2.2 kilos. But this is something that I encountered, so I thought I'll share it with you guys, and you can tell me what I have done wrong here. I can ask Marc to start this critique on this case, and then I can have the others quickly join.
Well, looking when you launched when you deployed the stent, I think you missed the orifice of the stent should have been more in the aorta. Probably your stent should have been a little longer. And if your stent would have been 5 millimeters longer, you would have had a perfect result. Yeah. But and I think I would be very much afraid of launching the stent with that view. Agree that it is well into the pulmonary artery, that's safe. But looking at the view of where your stent is, I mean, within a few millimeters, you don't really know where it is. And so I think you just missed the orifice or the junction with the aorta. So either a longer stent or a few more millimeters proximal, but provided that you still keep the pulmonary end covered, of course. Yeah, you must cover both. That's what I say. When I advance my stent, I always have not open, but I mean next to my table, the two other sizes, 3 millimeters more, 3 millimeters less, and I will not hesitate to exchange a stent if especially when it's too short. Yeah, because to avoid this, even if your wire would have been still in the position, it would have been still a nightmare to get the second stent in that stent. Yeah,
Yes,
I'll show you in my talk a similar case where the stent was too short and kinked. And once you get a kink like that, it's even with the wire in a good position through the central opening, there is no guarantee that you will get your stent over there.
So I think your points are very, very important, that, you know, both ends need to be covered. But you will agree, Mark, that there is some amount of guesswork here, and having a second stent of a slightly different size, often a little larger than what you have initially taken, is a very important fallback plan, which I think is very important. Our problem is that we don't have that kind of hardware availability, and expense is a big issue in our setting. So this test does come in our way of doing these procedures, and that's a bit of a problem. And I don't know if others have encountered something like this. If you have, then
one of the options is what the adult people practice. You know, they take a bare balloon and see if the length is appropriate, and then choose the stent length according to the length of the balloon which they had initially.
I used to think of doing that, but I found that it just does maneuvers too many things into the ducts, and, you know, the duct can go into spasm and make the patient unstable. So I really try to minimize transitions across the duct, and, you know, essentially try to go in with make a perfect judgment on the right size. And I think the point that Mark made is very, very valid. We must have backup stents, really. And whenever you realize you're falling short, which you may, because it's such a judgment call, you must be willing to take off the stent and get the next size in. I think that's very, very important. But that brings us to the point of additional stents. You know, no matter how perfect you are, your hardware may not be adequate. So we may have these situations where you have to put in like these really long stents. You may not have that on the table. So here is an example where I've had to put multiple stents into this particular patient, and you know, that's a tricky situation, because getting the second stent into the first stent isn't as easy as it seems. Again, I'm going to ask Mark, and then I'm going to ask the others how they have circumvented this problem.
Well, remember the first question you asked me, which stents do I think are difficult? Well, this is one, because it's long, and typically in most ducts, I always will say, try to do it with one stent. Now, this is the example where that is the exception. If I will show you later on a case where I did it with one stent, and the result was bad. Yeah, and you will see why. So here, I think it is either you use the self-deploying stents, but I mean, they were on the market in Europe, but because of new European regulation, they came off the market, so we don't have them anymore. Or you go straight for two stents, but I would have used the first stent a little shorter. You see your where your first stent ends, that is a place where you can kink. And if you're unlucky, it will kink. And then you will have a hard time getting your second stent in. If you would have taken your first stent a little shorter, then the angle of the second stent entering the first stent is much nicer. And so I would use the first stent shorter, and the second then, of course, a little longer.
Okay. So, you know, this is the thing that I think we've discussed all these issues, and we make sure. And do you use echo on table, Mark and others? Mark, do you use echo to make sure that sometimes the angiography doesn't tell you as precisely as the echo may tell you? I
mean, I have echo on my cath lab, but I would say that usually the angio will tell me what I need to know. I rarely will use it in the cath lab during this procedure, but I can imagine that there will be some cases where you might.
So I really would like to stop at this point in the interest of time. There are a few other issues and there are a few other cases, but I think in the interest of time, we'd all like to listen to what Marc has to say. And then we could go back and take questions from the audience and actually maybe share some more cases at that time. So Marc, I'd like you to share screen, and we've got lots of questions, and it's maybe we'll answer them all together once Marc is done with his talking.
Okay, so the talk I'm going to give is actually based on this article which was published last year, and I have no disclosures on coronary stent. It was our experience on our first 100 duct implants, and actually it was 123 patients, but many in those days, we're talking about so a long time period, were referred to the surgeon. Sometimes because I was scared in a very tortuous duct. Sometimes it was patient preference or parent preference. Sometimes it was referring physician preference. But so almost 100 ducts. And there I saw that for me, there are 9 subtypes, which all have their particularities. And that's what I'm going to discuss with you. So you have the short and the straight one, like in pulmonary atresia. You have the tortuous one, the most difficult one, like in fallow pulmonary atresia VSD, and then something in between, the more horizontal one. Then the subclavian to 2 lungs, the subclavian to 1 lung, and the aorta also just to 1 lung. Here you see all the cases, and allow me just to rush through and go immediately to some of the hardware. So nowadays, I almost exclusively use the 4 flexor Cook sheets. I think it's the 45 centimeters. And even when I have axillary access and you could get away with a short sheet, I prefer this sheet because then the person who is working at the skin has some place, and the other person that is working for the stent has also some place at a distance from the patient. I almost 100% of the cases, I use the ProGrade to position my wire as good as possible. Once I have this, I use the Ironman. The Ironman is for me the stiffest coronary wire that you have, but the transition is very brisk, which is very nice because you lose little space in the lungs. So you have the hardest part of your wire exactly where you want it to be. Sometimes, however, if you showed also, KK, a slide where your wire entered and bounced back on the pulmonary valve, then you have very little wire. There I would prefer, for instance, the excess support. It's the same final wire, but it has a longer soft end. The stents, here you see them. I use biplane. For me, it's extremely important that you have 4 to 6 coordinated hands, and those hands can even cross themselves. So the person on the left side, at the skin, his responsibility will be keep the sheet in position, especially in the tortuous ducts. Losing that position may kill the patient. It is the most boring job, I think, of the whole cath, but it is the most critical one, because if that person doesn't do a good job, failure may ensure. You need a friendly surgeon. That is very critical. This already was a little bit discussed. So the access can be venous through a VSD, venous through an atretic pulmonary valve, which is then burned, femoral artery, or from the neck vessels. And we already discussed a little bit when to start the prostaglandin. So fetal diagnosis has changed the natural history, and so sometimes in a straight duct, wait until you start the prostaglandin, because otherwise you end up with trouble. Typically, I will have ibuprofen in the cath lab for intravenous addition to get constriction if required. I must say I sometimes use it, but I'm not impressed by the results. I have my aspirin, and then I also have antiplatelet drugs, but I very, very rarely will use them. Yeah. Let's talk first about the short and straight one. So after you burn the pulmonary valve, your wire can go through the duct, and you see most typically there will be a constriction at the pulmonary end. But look at this duct. I mean, it's a huge duct, and it is a typical image. We did quite a few of these patients, but in the beginning, we had 5 failures, and those were exclusively because the duct was too big. There was no retention for the stent to be put in the duct. So all those 5 patients were then taken 2 or 3 days later after a long stop of prostaglandins. And indeed, in those days, the patients were born, they were started immediately on prostaglandin. Then you stopped the prostaglandin before the procedure, but it may take 2 days, 1 day, 2 days, sometimes even 3 days before that duct goes into constriction. That's why I recommend after fetal diagnosis, allow that duct, that type of duct first to go into constriction. Here, I mean, we launched the idea, go from before the pulmonary end until the aortic end. And so usually you will have an ampulla at the aortic end, but I mean, it's probably safer to have some protrusion into either the pulmonary trunk and in the aorta. In this patient, you want to have them a little bit bluish. I wouldn't start with somebody with a saturation of 93 because that means the duct is wide open. And then, I mean, here you have all the time in the world to get your duct in position. Checking the final position, this is a pure lateral, and I always will have a good reference here with the esophageal thermometer. That will tell you exactly then, you know where the aortic arch is, you know where the pulmonary end should be, and there you can, those ducts are really easy, provided that there is sufficient constriction. Allow me then to jump to the most difficult ones, the fallow, the vertical ones, the tortuous ones. And so you spoke about tortuosity of 180 degrees. I mean, most of these ducts are much more complex. I mean, this duct, for instance, it will go down first, come up again, that's already 180, and then go down like this. This is already 270 degrees. And then in the AP, it will first go here, and then it will come straight to you. That's almost another 360 degrees. So much more complicated than sometimes you will see. And indeed, if you look at the pictures from the CT, beautiful pictures, but they tend to scare me more than I mean, if I think if I would do CT in all my patients, I probably would be scared more than instead of trying it. Here's, for instance, a case that was published quite a few years ago, but it illustrates nicely what can happen. So it's a duct here. It goes like this. This is a lateral, 180 degrees, and then it comes back like this. Now, there is not a single stent that will take all these curves. Your wire will straighten out, or the stent will straighten out all those bends. So there is no point in measuring all this distance because your stent will never do that. Your stent will go from here till there, full stop. Yeah. And so here again, the use of the microcatheter, I go with this carotid approach, microcatheter. So it goes into the duct. I try to get my microcatheter as far as possible. And then we put the stiff wire in it. Now, do note that once you straighten out that duct, you get spasm of that duct. And you have to realize that. So from that point on, saturation will start to decrease. At this point, you are committed to success. There is no way back. If you pull everything back, your patient may die because there will be an ongoing spasm of that duct and you will never be able to recross it. So you must be successful in this case. But so here you see then my injection once the wire is in place, and now you can It's a straight course. Now it's much easier to measure. But again, this corresponded very well with the measurement we had from the echo. You put then your stent in, and here again, you see that we reach the pulmonary end, so that's perfect. And over here, whoops, I restarted. Well, you will have to believe me, but I mean, it was also reaching the aortic end. You inflate the stent and you get the nice result. Note that indeed the stent did straighten completely the duct. All the curves are gone. I mean, I don't know a stent that will take all those curves. You will straighten them. So in this population, we did 25. And the failures were typically when we came from the femoral artery with instability of the wire, instability of the stent, spasm, and things like that. Once we shifted to carotid artery or subclavian artery, we had a near 100% success in all those patients. Then the intermediate is something in between. So here you see indeed it is the more horizontal, but with a bend over here. And indeed, again, we go through it with the microcatheter. You position it, that microcatheter, it will follow every bend of your duct, but once you put in the wire, it will straighten out everything. Again, you get spasm, you will get cyanosis, and then your time is limited. You have to proceed, and you are committed to success. Here you have to be a little bit careful because the duct may enter sideways the aorta. So don't get fooled. And that is one of the questions that the echo has to answer. Where does the duct enter the aorta? Is it really anterior or is it sideways? And most of these ducts will leave the aorta on left lateral side. So that means that you have to protrude a little bit more with your stent into the aorta. Otherwise, you get the same problem as KK, namely that the stent is too short and you will get kink at the origin of the pulmonary end. So here then we implant this stent, and okay, rough day, the pulmonary end is not perfect, but you're still in perfect position to enlarge this. See how the kinking of the duct around the stent. So everything needs to be big enough. We added a second stent, and so finally a perfect result. Now, when publishing this series, we got a big comment that on the average 2 to 3 months after the initial procedure, we had a repeat procedure, and the reviewers considered that as a failure of treatment. I would not consider it as a failure of treatment. I mean, this shunt is you see that there is protrusion of ductal tissue into the stent, and it is very beneficial to give that stent a second wind, that shunt a second wind, so you can get maximal growth, catch-up growth of your pulmonary arteries. Especially in patients with single ventricle, it is extremely important that before you go to the glen, you get all the catch-up growth that you can get from your initial shunt. And for me, even the surgical shunts, we will enlarge them 3-4 months after initial placement to get maximal growth. Sometimes it may then be difficult to find the exit hole, but I mean, it's a piece of cake to enlarge this stent and get the most growth out of your pulmonary artery. Again, so these were more horizontal, moderate tortuosity, and nowadays I think we could go almost for 100% success also in those patients. And the other variants, so the 2 lungs coming from the subclavian artery. And so here's that example of the very long duct, where then the microcatheter takes its bend on the pulmonary trunk and it's parked over there. It looks easy. And in some patients, it is easy. And indeed, you can put a long stent, and indeed in this, the body then will force the stent to take a curve. But now look at this patient, what happened over here. Maybe agree that the stent is slightly too far over here, and that KK is exactly the same thing as you showed us. So we start inflating the balloon. Whoop, it should go up. And that is rather unpredictable what is going to happen. ups, it straightens, and I think nobody will have good control. Probably if I have to redo it, I will start the first stent with a much shorter stent and then get the second stent in. Now in this patient, indeed, that part was sticking out here, kinking the duct over here. You see we had a dissection over here. The stent, because of its straightening, was too far in the pulmonary arteries, and there I chose to send this patient to the surgeon because I had no trust whatsoever. And so even with my wire through it, I was unable to add a second stent. So in this specific long duct, I would go for 2 stents, but definitely shorter than this one. Here then the example of a single lung on one duct. And as I said, most of these patients are a fallow type, and the other lung is good and again will provide good saturation. So these ducts have a very, very high tendency to close themselves within hours after birth, despite your prostaglandin. This is the kind of kid that I will take within 24 hours to the cath lab to get the stent implanted. All the others can wait. Here, another example where, again, the duct was closed, and usually it is rather easy in this fresh constriction to cross it. You put your wire in, but note over here, for instance, a big thrombus already in that pulmonary trunk that with the stent, we got a nice result. We could salvage the lung and then later incorporate it in the complete situation. So that sometimes you have it's from the cross, like the typical duct, but only going to one lung. Here, that is a patient actually with bilateral ducts, and here it's coming from one lung. So you see that we had implanted the other duct, another stent, but I must admit, too long. Similar problem, I mean, misjudgment. But in this duct over here, it was adequate, and so this was then the final result in this patient with bilateral lung. That was a case of right isomerism. This was the neonatal procedure. This kid is now 4 years old. It has undergone in the meantime 3 other procedures, and both these shunts are now put at 6 millimeters. So you can stretch, you can break those coronary stents with the high flow, high pressure. And this patient will have to go to a Fontaine type of circulation, but we're still figuring out how to make here central pulmonary arteries in such a situation. So here, again, all the 6 cases. So the technical issues is, are you talking 1 or 2 lungs, the origin, the angle, length, tortuosity, the brittleness, the size, ductal tissue that will extend into the pulmonary artery, and complications. You must be aware there can be spasm, dissection, inability to position your stent. But again, now that I have my flexor sheet in front of the duct, I mean, that has become history. Acute thrombosis can happen. You can jail pulmonary arteries. Early cyanosis because of abundant tissue prolapse of the ducts through the mazes of the stent. Incomplete covering, and that you should recognize as fast as possible. Over shunting if your stent is too big. I typically will then give NSAID, so ibuprofen or something to get maximal ductal constriction, and usually within 2 or 3 days it's gone, or otherwise the typical treatment. I had to downsize one stent by putting in a covered stent so that I could decrease the flow through the circulation. Be aware if you open a pulmonary valve for the circular circulation, especially when there is a significant tricuspid regurgitation. The late cyanosis because of ingrowth of tissue and peel formation. And as I said, I nearly always will give a second wind to the stent, especially in single ventricles. Fallows may not need it, but future Fontaines may need it. So my conclusions, ductal stenting is feasible. Indeed, it is demanding. It requires planning, good tools, experience, some guts. I think not too big egos. and a team with 4 to 6 coordinated hands. Very important. And also a friendly surgeon, because you will run one day into trouble. I think so far no interventionalist has claimed a 100% acceptance or success. The ones that did, after a discussion with me when I presented them then some difficult cases, they said, oh, I don't think I would like to do that case. And I think we may not forget that there is no dishonor in referring a patient to the surgeon. That's all I wanted to say, KK.
That was fantastic. I think it was really the icing on the cake. I think it covered a lot of the areas, and I've learned a lot. No question about it. I'd like the others to comment. Radha and Shreepal and Nageswara, please.
Marc, how many times have you re-intervened on a stent, after doing a stent and before he goes to the second stage of palliation? Have you had to go in and balloon it again? And if that is so, what is the frequency or percentage of?
So you don't refer to what I would call procedural failures, where you have to go back within 24 hours or 48 hours, because that's a technical issue. Okay, but we're talking about 2-3 months later. It depends. So a fallow, for instance, may not need further growth, and there you have a ventricle that will make the pulmonary arteries grow. And so the initial stent may do the job. In the case of pulmonary atresia, intact septum, once you open the pulmonary valve, the right ventricle may grow, and so you may no longer need that stent or the duct after a couple of months. But specifically, I'm talking now about the single ventricles. There, I have almost a religious belief that you need to have all the growth you can get before you go to the glen. And if that means that you give a second wind to whatever shunt, whether it's a stented duct or a surgical shunt, I would give that second wind to get maximal growth of the pulmonary arteries. And so typically those patients, after 3 to 4 months, will come back to the cath lab. By then they will have a saturation of low 80s, high 70s, and I will expand that stent. Don't forget, nearly every coronary stent you easily can dilate up to 5 millimeters, no problem. Yeah, but typically I will put a second stent in there, and then you have a big shunt. I mean, you can easily go 4 to 5 millimeters and give a second wind to that shunt. And it takes a long time to prove that our fontaines are doing better, but I mean, they're doing good. I mean, I love to have my fontaines with big fat pulmonary arteries. The bigger, the better. Of course, you may not blow the ventricle apart. You may, especially when there is a tricuspid valve, you should be a little bit careful. But the worst I think you can do is put a minute shunt in a neonate and then go for an early glen because this patient is too blue. I mean, you will end up with a bad fontaine with minute pulmonary arteries, and there is no way then that you can get catch-up growth of those pulmonary arteries. And so
you go another bigger stent over that stent, or just dilate the stent and come off?
Both. If there is a significant amount of peel inside of the stent, I would go straight for a new stent and bigger stent. So let's say I did put a 3.5 in there. It may have shrunken down to 2 millimeters or something. Depending on the weight of the patient, I will go for a 4 or a 4.5 new stent. And if I'm still unhappy or the patient can take it, I will not hesitate to go in there with a 5 millimeter balloon and put it all the way up to 5 millimeter. Both stents then.
One more question. Are you now worried about the LPA being jailed, or would you just go ahead and stent it? Like, for example, the duct causing LPA coarctation.
Yeah, that's a bad thing. And so again, if that happens in a fallow, you can live with that and you can solve that problem later on. If that happens, however, in a single ventricle patient, I may go back after 2-3 months and try to enter that and dilate it. But if it doesn't work very well, that is one patient where I will ask my surgeon, put a small blaloktasic shunt or a small central shunt on that left pulmonary artery, have both grow. And then by the time you go to the glen, then at least you will have two nice pulmonary arteries. Yeah. Don't expect
crossing with a separate wire into the left pulmonary artery in the first procedure itself, and then
no. I don't do that. I'm already happy. I mean, so my strategy is I almost always will use the microcatheter. Then I put my stiff wire in there, and because that allows me to see exactly what my stent will do to the duct, and that allows me, I think, to have a better assessment of the length I need. But because that maneuver will induce some spasm, you don't have time to put a second wire and things like that. I mean, you must go fast. You have, I think, 180 seconds to assess, place your stent, deploy it, and get out.
And then leave the left pulmonary artery for a later decision, either a shunt or cross it again.
But again, most of my patients come as newborns, not when they're a few days old. So, and my neonatologists, I mean, they are extremely keen to start the prostaglandins. So I almost never will see a left PA stenosis before my catheterization, because the prostin will have been there and it will have prohibited the coarctation on the left PA to form. I think it's a different population that you see. I think by the time they get to you, the duct will have constricted more or less. And if there is extension of the duct into the left PA, you will know. I only will know a week after the procedure, a week after we have stopped the prostin, typically a week after the stent.
Thank you.
Nageswara, Shreepal, please.
I think he answered most of the questions. It's a wonderful presentation. I thoroughly enjoyed a lot of cases. Only one or two questions. Would you like to prefer to keep wire in particular pulmonary artery, or it doesn't matter in the absence of main pulmonary artery stump? You have a duct which is giving both the pulmonary arteries. Do you have any preference of keeping right PA or left PA, or really doesn't matter?
I think it doesn't matter, because I will try to have my wire bounce back on the pulmonary valve into either pulmonary artery, and actually I will not use that wire. I will have it bounce back just for stability. Yeah. The other option is that the frame that you saw from KK, where he did put his stiff end of the wire against the pulmonary valve, and he had the soft end curl back. Yeah. You can do it also that way. Then you don't enter any of the pulmonary arteries. However, you only have 2 or 3 centimeters safety margin of your wire, and so that's where your 4 or to 6 coordinated hands are become very important. 1 centimeter in a newborn, I mean, you lose it in just cough and you're gone.
Shreepal, you had a question?
Yeah, that was an excellent talk, Professor Marc. Really lots of learning points for all of us. My one question to you is, in cases of bilateral PDAs, how do you determine the length of the stent that you're going to use? So is it based on just the point of narrowing that you have to cross, or is there some other way that you're deciding the length?
So, I mean, whether it's a bilateral, yes or no, it's not that important. It is actually twice a duct to a single lung. I mean, and that's a strategy. And well, I would say exactly the same thing. Get your stiff wire in there so that the wire will tell you what will happen to that duct, and then assess its length. Now, usually you will have the last case that I showed there. So the second stent, I think it was the ideal length. But what was the duct coming from the arch itself? The other duct, the duct coming from the brachiocephalic trunk. Actually, the wire had not straightened the duct, and it did curl. And by the time I did put the stent in, the stent did straighten more the wire. And that is something that can happen if you use 2 soft wires. I mean, the wire should straighten your duct the way the stent will do it, and then you have the best estimate, I think, of what the stent will do to the duct. But once in a while I'm wrong. I mean, in the patient I showed there, I was a centimeter out, too long, way too long. The thing is, I don't mind with the 4 French flexor sheet, I put the stent, I make my angio, and usually you can really assess both ends. But also in the brachiocephalic trunk, it is hard to see where does the duct begin and where does the subclavian go. I mean, that is not very clear sometimes, yeah. And indeed, sometimes you have to decide within 30 seconds, do you proceed, yes or no?
There's a question from the audience, and what I would ask Marc is that in a very tortuous duct, I think you showed an example with a 180-degree bend. After you've successfully placed the stent and you remove the guide wire and the stent buckles and there's a sharp bend in the middle of the stent, you've taken out the guide wire, SATs are low, what are the options? Looks like a problem that some of us have faced.
Yes. And I think, I'm afraid it's a problem we will face more often, because the coronary stents, obviously, they are not made for us. They are made for the coronary guys. And so what do the coronary guys do? First of all, they want to get their stent in very tortuous coronary arteries. So they want to have them as soft as possible. And what do they do nowadays as well is open the side branches. So the newest generation of coronary stents has very little metal, is not very strong, very flexible. You can get anywhere you want to. And the side vessel accessibility is enormous. But translated to our situation is, if you put a stent like that, what you just described, the duct may break the stent in the middle. Yeah, and that's exactly what you don't want to have. So the best stents for us were the ones from, let's say, 3-4 years ago, with a lot of metal, yeah, strong, that will straighten the duct and make the stent almost unkinkable, yeah. And what you describe over there, what are your options? Well, they're all not good. Either you have to recross the wire, that will be already a challenge, and then recross with a stent. But that may be a very big option, because in a kinked stent, the first stent will scrape off the second stent from the balloon. And so that may be a problem. Sometimes you have to pre-dilate with a balloon or with your dilator sheet and get in there. And sometimes you have to tie up and as the surgeon to bail you out and put a shunt somewhere. So, but this is a typical problem that we will face more and more often when we start using coronary stents from the newest generation. So recommendation, go for a stent that you can see real well on scopy. It must have a lot of metal. If there's not, we don't care about side branches. No? I mean, the duct has no side branches. We don't care about that. And the stent must impose its solidness to the stent, to the duct, and not vice versa.
What I have found, Marc, in these desperate situations is that local installation of prostaglandin keeps the patient alive till you can take the patient to surgeon. And I found that useful. The other thing that I have done, it's gutsy, but I've been forced to do in one situation where I had an instant occlusion. I'll quickly share screen and show you that example. It's been my worst nightmare with a PDA stent is when I had an instant occlusion. And this tends to happen more often in older children. And so this is what happened after I put in the stent. Everything was perfect. Everything went well. The patient I was going to even remove the access, and suddenly started to desaturate, and there was this big mass of thrombus within the stent. So in this particular case, I actually pulled out the stent. I snared it out, and the patient was salvaged. There was a period of significant desaturation, but we were able to send the patient alive by completely snaring out the stent. But these are horrible situations, I agree. And I think if you do numbers, you're going to encounter them. It's just a matter of time. You will encounter one such complications. That's what I feel. This is something that we all have to be prepared for.
Yeah, I fully agree with that. I mean, most procedures we can predict within a 99% margin the success, or at least the absence of a major complication. My biggest complication that I've had was a similar occlusion like that of a duct, which what I would have called the most straightforward case book procedure that you could imagine. And all of a sudden, shit that hit the fan, and the stent occluded without an obvious reason. And so that one I had to salvage with putting 2 other stents and finally a covered stent. And in the meantime, I had given him all the platelet inhibitors that this hospital I could find. So, I mean, horrible situations do happen. And that's why I started with my first slide. It remains a balance between how do we assess the risk of the procedure. And I think it's more likely to happen with the curled one, even if everything goes very well. Versus what can your surgeon get. And there we must say that a surgical shunt is also not free of any complications. Yeah? And it is one of those procedures where I don't think it would be foolish to guarantee a 99.9% success in advance to the parents, because everybody with enough experience knows you shouldn't do that.
Another question from the audience on the role of self-expanding stents. I think that is in short supply in these sizes that we want, but I'll have Marc answer that. I think it's useful for duct-dependent systemic circulation, where you want to stent the duct in hypoplastic hybrid procedures. But here, I don't see the role so much.
Well, so indeed, but for these sizes so short, for this type of duct, we had a 4 millimeter self-expanding stent available in Europe, but the European community demanded a complete revision of all the implants. And so every company has to go again through the system of homologation. And the turnover of that stent was so low that the company just decided to take it from the market. So the self-expanding stents that Dietmar Schans did develop, I mean, it was his life work for the last 10 years, has been abolished because of regulatory things. And I mean, that stent, for instance, I think it never got on the market in the United States. And I don't know whether I don't think you will ever get it in India as well, because I mean nobody will make it anymore. It was a nice stent though, and typically that long stent that I said from the brachiocephalic trunk, that would